folks. So it's my pleasure to introduce this amazing team from WashU, as well as Uganda here, Mr. Allen and Samir. And so we're going to be talking, our official title is Insights from the Suubi Adherence4Youth trial, which is a psychosocial and economic empowerment intervention. And so this is a collaboration, like all good collaborations, goes back to Tor, who introduced Fred and I, and said, Fred's got this great trial, it works, let's need to figure out how to optimize it. So that's how we got connected. To introduce Dr. Fred Sewamala, he's a William E. Gordon Distinguished Professor at the Brown School of Social Work at WashU in St. Louis, founder of ICHAD, which we'll be featuring and talking about today, which is done. We have information sheets here. It's just done incredible work. So many NIH-funded studies. It's partnered with 50 plus local schools, 40 clinics, multiple CBOs. And so I'm lucky to get to be a part of his network now. And so we have another group. So this is Mr. Allen. He received his degree in software engineering and is the primary story coordinator for this study, which is incredibly complex. So I apologize, Mr. Allen, for designing it in this way. But he also manages the IT at ICHAD. And so he's sort of really leading and coordinating a large group. And so we're very glad to have him presenting. Portia is here as well. She's a PhD student at WashU and study coordinator for several trials in Uganda. Rachel over here is an assistant professor at WashU who does modeling work in mental health and outcomes among adolescents in low middle income countries. And then also Samir Jamidu's here as a guest who received his degree in medical laboratory sciences and is at the Rukia Health Science Program. So with that, I will let Fred do the intro, and then we'll go around and if there's questions in the chat, we'll be monitoring that. But also maybe feel free to raise your hand and go from there. Yeah.
Okay, thank you so much, John. As John has indicated, I'm Fred Sewamala. I'm one of the trainees who went through CAPS program, the VIP program, back in maybe 2007, 2008, something like that. And I always tell people that when you begin a mentorship program, and if it turns out well, you are a member of that family for life. So To and I have worked together since then, and I've really, really benefited from CAPS more than they have benefited from me. And I consider myself extremely lucky because one, working with CAPS gave me a chance to do some bidirectional learning, what we are learning globally, how to bring it in New York. But then it also launched me as a scholar in a way that really, frankly, my doctoral program itself didn't. I'll say that. So I believe in capacity building. I'm glad to see Craig here, a colleague now, heading one of the consortiums. I lead one, and because I really genuinely believe in capacity building, and because of what has happened to me. So when I do work around capacity building, it's not simply because I've seen others; it's because I've benefited from it. So Toa, thank you so much, really for years that you have really invested in me. Now, each time you get a chance to present, I speak, it's 11:07, by 11:15, I need to be done. And then I'll pass it on to our engineer here, Mr. Alan Mugarura. And I have to tell you something that Mr. Mugarura is standing for Member of Parliament in our country because, because he came to the US. So, when you come here, that's a ticket for you to be able to be elevated to the next level. So yeah, but without seriousness, each time you get a chance to be able to share your work, I always want to begin. Where did I start? So I want to, if you go to the next slide, So really, with this kind of work, you need a village to be able to engage in this kind of work. And these are some of the people that are really supporting the work that we are doing with John. John, I'm extremely grateful. I know I passed him because you had already spoken, but I'm extremely grateful for the partnership. He has visited Uganda and he's coming back and he'll keep coming back. So in the next slide, what you are going to see is really what inspires me, what inspires this work. So we are interested. I believe that most of the medical doctors do a good job around diagnosing disease and that kind of stuff. Behavior scientists, I think where we have failed is for us to identify the social determinants of health. And the issue around HIV and AIDS is not simply because people are more promiscuous, people are doing the other, but because they are real social determinants. And one of that social determinant is poverty. And what we've done is to include that in a regression. Each time we work, we say, let's include that as a control. And for me, I'm always asking a question, how come we don't do something about it? How come we don't design interventions? How come we keep blaming people for non-adherence? Because, these people, they want to be like any of us. So we have really blamed the non-performance of some of the interventions on the individual attributes. And yet we know that society and the environment we live in plays a very, very big role. So our aim at the International Center is to contribute to the reduction of poverty as a social determinant of health, with a thinking that we will be able to contribute to public health outcomes, positive public health outcomes. And we do this in several ways. The first thing we do is we try to test out applied interventions which are very innovative. The other thing we do is afraid tomorrow we retire. Who will move this work to the next level? We try to build capacity so that this is not a one-man show, but it's all the people that we brought. These are all young scholars who will move this work to the next level. But we also want to be able to raise awareness and say, really, these social determinants are critical. They're extremely important. There's something we need to do. We need to do something about them. And then we also want to be able to inform public policy. So that's what really we do at ICHAD. And the next slide, I try to clearly indicate, try to make a case on why we focus where we focus. So the poorest region on Earth is Sub-Saharan Africa. That's a fact. I'm at CAPS and you guys, you do global work. 413 million people out of close to 700. Please help me. Yeah, because he's enjoying my talk. Help me, please. So 413 million people out of almost 800 million live in this region, Sub-Saharan Africa, okay? And when you look at Sub-Saharan Africa, the majority of people living in Sub-Saharan Africa are young people ages 5 to 24. So look at that, you are having a big number of young people growing up in poverty. On the next slide, what I try to show is that the same region where we work has the biggest number of people who have been affected by HIV and AIDS. And by the way, that's not only Sub-Saharan Africa. Even when you come in this country where I have done some of the work, areas which are poor are also more affected by these poor health outcomes, including HIV and AIDS. Now, the challenge we have on failing to get to 95 goal is that over half of the people who are infected with the HIV and AIDS don't know their status. Okay, they test, but because of stigma, they don't go for the results, or some of them even don't test. Now, what does 25 million represent? When you look at the far right, those 4 states, Colorado, Missouri, I think Illinois, and one other state, when you get that entire population, that's what 25 million represents. I mean, that's big. If you went to Illinois and everyone in the state, not in Chicago, and you went to Wisconsin and everyone in that state, and you went to others, and everyone is carrying the virus, and it's beyond simply a pandemic, but it's really an epidemic, which is really, where something needs to be done. Or if you get the 2 top states, the top states, which is New York, if you hit, please, which is New York and New York And then I think Kentucky, those two states, if everyone in those states was infected, that's what 25 million represents. In the next slide, what I try to show is that at least it's very clear for medical. I'm not a medical doctor, but even medical doctors know that really poverty impacts us in multiple ways. We know that poverty has a direct relationship on our communities, and communities which are poor are more likely also to be affected by disease. And then there are all, increased risk factor as a result of people living in poverty. There's a direct relationship on both physical and mental health functioning. And so the reason I bring this animal called poverty in the room is because that's what we do at ICHAD. We try to make sure that if we infuse resources in the households of young people, will we see financial stability? Will we see these young people and their families engaging with opportunities? And so will we see better outcomes? Really, that's what we are trying to figure out. Because even in a country like Uganda, where ARTs are free, a group which is non-really adherent are young people, especially those who live in poverty. And the issue is, it doesn't mean when you make it available that people will use it. Because young people tell us, yeah, I would have wanted to take ARTs, but I don't have food. And these ARTs are extremely strong. And if I take them without food, I get nauseated and I will throw up. And they don't want to do it. So if they had the food, which can be addressed by simply a supply of food, if they were not poor, then they will take the medication. Or some of them also tell us that I don't want to go to the closest clinic because of stigma. I want to go to the farthest clinic to get my medication. And to get to the farthest clinic, you need transport. And without money, you can't get there. So hopefully infusing resources will address that. On the next slide, what I try to show are the different studies that we've done over a period of time. These were smaller studies to begin. But the reason I always want to show this is because people always say, oh, Fred, you've been successful. And they think that, I was given a baseball, is it on number 3? How do you call it?
You landed on third base.
Yes, that I landed on third base. I just whatever and went home. No, I started small. I started with about $3,000. And when I worked at CAPS, I think when I came to CAPS, I think they gave us 8,000 or 12,000 or something like that. So I started small, but these studies were able to allow me to test out the ideas I had around issues of poverty. Does really poverty matter? If you infuse resources, we will see a change in the way people engage with public health interventions. And so I was able to test the feasibility, the acceptability of some of the measures and the interventions. And now, but because these studies were smaller, if you go to the next slide, I was able now to say, yes, we have established feasibility, we have established acceptability, and we are seeing preliminary outcomes. And that's really what launched us. I always tell my students that get that data, tell us whether this is feasible, whether this can be done. And since then, we've been able to apply for over about 15 different RO1s and R34s, and we are really working in Sub-Saharan Africa. The dominant place where I work is Uganda, but we work in Rwanda, we work in Ghana, we work in Sierra Leone, we work in Kenya. And now we have taken that work to be able to think about capacity building. Because for me, I'm not a basic scientist. I'm a behavioral scientist. So I'm using this as what you call social labs to train the new cadre of researchers, to be able to use that data, to be able to go to the field and see how work is real done. So those 5 grants you see below, there is a D43, which is funded, which is called, Achieve, part of the launch program. That's how I get to know Craig. There is another D43, which is a child GRF. There is an R25, there is a T37, and there is another R25. So that's how we have built this. We are using the field studies to be able to inform our capacity building. And I think I'm going to almost stop there. If you go to the next slide, so this study is the study on which Johnny's work and my work is based. This is a study. I'll tell you briefly about the study. The study is called Suubi Adherence. This is a study which was funded at R01 level with about $3 million by NICHD. And the question we were asking in this study, if you go to the next slide, was to what extent, given that in most of these countries, ARTs are free, but there is still an inability for people to pay for transport. There is still an inability for people to pay for meals. If we infuse resources and through economic empowerment and economic empowerment intervention, where you train people on financial literacy, get them some financial grants, encourage them to invest in small business development, and then be able to use that money for drugs, will we see a difference in people's adherence to treatment? And when you go to the next slide, and the next, so that was the overarching question. And so we worked in 40 clinics. We recruited 726 participants, and that was the inclusion criteria, and we used multiple measures for us to see in terms of adherence to treatment. And on the next slide, what I show is that after about 2 years, and this was extremely exciting, we saw that young people who were given an economic empowerment intervention were more likely to have a viral suppression. In fact, we saw a 9 percentage point difference between those who were reporting viral suppression in the control group compared to the treatment group. So the treatment group did far much better. And this work is really published in both in AIDS and Behavior, and I think another journal. So we saw that. And this was really, and then when we look at the next slide, and I think the next slide, we put all that together. This is to give you the background to the work we are doing with John. We put all that together and we looked at the other studies that I've shown you. And we said, you know what? The economic empowerment intervention has something positive that it's bringing. So how can we now optimize, try to figure out what combination of that intervention works and what is the cost and what is scalable? And that's where we are right now. And that's the study that Alan and John are going to take us through. But that was the background on how we got here. Please.
Thank you so much, Dr. Fred. My name is Alan Mugara, and I'm a study coordinator for the Suubi Adherence4Youth study. And I'm going to take you through, first of all, to share with you what Suubi Adherence4Youth study is, and then to take you through the progress of how far we are as a study. So
maybe what I didn't add was that the earlier study ended after 5 years, and we applied for competitive renewal. So this, what we are now seeing, 7 years later, what is happening? So we are able to go back to the same children and try now. We are trying to follow them over a period of time. Okay.
Thank you. So I want to start with the word Suubi itself. Yeah, Suubi is the Uganda word. It's our local language, and it means hope. And I really want to thank Dr. Fred for choosing that word, because even when you are going to the field and you talk about hope, it really motivates these young people that we are working with, the population that we are working with, to be able to actually understand what you're actually working with here. So Suubi is evidence-based and it's theory-informed, and it has 4 interventions. Here, what we are trying to do, we are trying to find, to optimize the 4 interventions that we have been using here at the International Center for Child Health and Development. These are interventions that have been done over the past 15 years, but we're trying to find out which one is the most efficient, affordable, and effective intervention. Basically optimizing the 4 interventions, trying to find out which one really works best. Yeah, so we have 4 interventions. We have financial literacy training. Basically, we have to infuse knowledge of financial literacy, basically managing your money in these homes. And that's the first intervention, where we bring in these families into focus groups and we train them on how to manage their finances in a home. And we also have a second intervention. Like Dr. Fred said, we have economic empowerment interventions, at the same time, psychosocial interventions. So the first 2, they incentivize matched savings accounts and income generating activities. That is a second intervention. or it is not really aimed at training, but also infusing the resources that Dr. Fred talked about. And this is how this is done. We basically create bank accounts for these young people living with HIV, and the way we motivate them to start onto increasing their resources is by motivating them to save onto these bank accounts. But the motivation comes in by having matched youth savings account, meaning that we have to match their savings. When they save, we also tell them, we are going to double your savings. So we have a match ratio of 2 to 1, meaning that on a monthly basis, we look at their accounts, how much have you saved? And then we double the amount. Yes, so they look at that as a motivation, and then they start saving. And we not only end on only just trying to really match their savings, but also to train them on how to start small-scale businesses. That is the income generating activities part of that same intervention. We have to train them. Yes, you save the money, but how are you going to now create investments out of this money? So that is the second intervention. That's a 1-year intervention, meaning that every month for 1 full year, we look at the account and then double the account. But we also have a match cap, basically how much can you really save and how much can we actually also double the amount, which is $10. Yeah, and we have psychosocial interventions. We have a manualized intervention for adherence and stigma reduction, also called Suubi Cartoon. And when it comes to Suubi Cartoon, this is actually a booklet with cartoons. And we all know how young people can relate to cartoons. So this is a booklet that has stories of young people living with HIV, and it goes on to tell the different ways of how to adhere to medication, dealing with stigma, dealing with family laws related to HIV and stigma. So that intervention itself, I can attest to you that I've been in the field, and most young people really adhere to the medication because they have seen in this booklet that if you do not take this medication, this is what is going to happen. The outcomes are there, they are visible in the booklet. So as we train them, they look at this manual or they look at this cartoon and they can relate to it. This is the life they live. But these are young people in the same booklet, almost the same age. Yes, and we have a fourth intervention, which is engagement with HIV treatment role models. Here we are trying to look at, these are adults, they are not really teenagers, but they are living with HIV. So we want to have really youths that are already living with HIV be examples to these young people, role models to these young people. If a young person can really look at someone and be like, she has made it with HIV, that means I can make it with HIV. So that is the fourth intervention. Now I want you to...
Question. Sorry, can you just clarify the age of the people in this intervention? Is it the same 10 to 16, or did you go a little older?
This is 11 to 17.
11 to 17.
Yes. Thank you so much. So now I want to take you to the gap. Why are we optimizing these interventions? So we are trying to have a factorial experiment to test and optimize the intervention to enhance, scale up health systems using a multi-phase optimization strategy, which is basically a way of trying to test these interventions, trying to find out which one is the most efficient, affordable, and scalable intervention. Yeah, so we have the 4 interventions there. We want to find out which one really works best. Which one works best, but we're not only ending on that. With the multi-phase optimization strategy, we are also trying to test combination, not only one intervention, but also test the different combinations of these 4 interventions. So that's the goal. The goal is to try and find out our Suubi 2.0 or an optimized intervention that can really work for our young people, which is efficient, affordable, and can be scaled to the entire region. So these are the study aims. So I think I've actually explained the first aim, but I'll go ahead and go through it, which is to conduct a factorial experiment or an optimization trial to test the main effects of the 4 Suubi intervention components. And I think you can tell that we are looking at viral suppression as our primary outcome. But we are not only testing the individual components, like I said, we are also testing the combinations of the components. So we are also going to look at how we are doing that. And the second aim of the study, we are testing the mediators, explore moderators to explain and modify the relationship between each of the 4 interventions. Here we are looking at how exactly these interventions going to be like helping our young people. Yes. So, and then we have the third aim, which is to compare the cost and cost effectiveness. We want to know really if we are intervening within these young people, how much is it costing at every stage? If you're going to the field and meeting with these young people, how much is it going to cost you? So if that, and I will go back to to what Dr. Fred said in his presentation when it comes to informing policy. If you're informing policy, you need to show them this is how much it takes to actually intervene with these young people. So that is our third aim. This is a conceptual model of the Suubi Adherence4Youth study. As you can tell, all the 4 interventions are there: the financial literacy training, the match savings accounts, the Suubi cartoon, and then the HIV care and treatment. So this just shows you how we are mapping from the interventions and what outcomes are we getting from this intervention. And Dr. Fred really hinted on all the outcomes that were gotten from the first grant of that of this study. So we are looking at our primary outcome being a sustained viral suppression, and our secondary outcome being adherence to the treatment, the HIV treatment. Allow me to go to the next slide. We had a question about the sample, and I want to explain it here. We are looking at recruiting 576 adolescents living with HIV, aged between 11 to 17, from 48 health facilities in the Greater Masaka region of southern Uganda. And the 48 clinics are randomly assigned to one of the 16 conditions. And I'll go ahead and show you how we are going to be doing this randomization or distributing these different conditions to the different clinics. So we have an inclusion criteria there, or basically what we look at as we are trying to recruit the participants into this study. We are looking at adolescents living with HIV, and they have to be knowing their status. You have to know your status before you are recruited within this study, and that has to also be confirmed by a medical report. We are also having, we are recruiting adolescents living with HIV who are living within a family. So that means we are not really considering adolescents that are coming from maybe they are living on the streets, or maybe they are in an institution, but really within a family, because like Dr. Fred said, we are infusing these resources. We want these resources to be within a family, and then we see how they can progress. We are also looking at 11 to 17 years. They have to be prescribed on art and enrolled on art within one of the 48 health facilities. This is the sample size. When we are looking at clinics, we are looking at the clinics that are actually accredited by the Ministry of Health Uganda, meaning that we're working with public health facilities, and with these public health facilities within the region that I told you about, the Greater Masaka region of southern Uganda. And they also have to be having the art clinic on them. So the exclusion criteria are basically when we are recruiting, we have to make sure as we are consenting these participants, as they are consenting to take part into the study, they have to really understand all the study procedures. They have to know what exactly they're consenting to. So if they can't understand that, that is the only exclusion criteria that we have. Okay, so now I want to go ahead and explain how the multiphase optimization strategy works here. This is the 2-factorial experiment. This 2-factorial experiment is going to be working like this. Like I said, we are looking at affordability, we are looking at time, money, and labor. We are looking at scalability. How exactly are we implementing within the real world setting? And then we are looking at efficiency. How well are the resources, staff, participant time? How are we managing all these? So these are the 3 factors that we are looking at. And so this is the main course of how we are actually dealing with the conditions that I told you about. I said we are not only testing the 4 interventions individually, but we're also testing the different combinations of the interventions. And from this, you can actually tell how we have, I think, columns there. We have the condition, and then we have the 4 interventions of the FLT, that is the financial literacy training, YSA, the accounts that I talked to you about, the art, that is the Suubi cartoon booklet, and then the role models, or adult youths that have lived experiences of living with HIV. So what you're looking at there is, I'll first explain this at the first row. The first row has on, meaning that we have a combination where all the interventions will be administered to the young people. And then we also have, let's say, the second one. It has one off, that is at the role model stage. And that means that that entire combination has only 3 interventions. Yeah, so that entire part, I just got a few of them. That is the first part that I explained, so that we can get to know how exactly this is working. And then I also pulled out the 5th row, which shows the 3 interventions. So there are other interventions. Not only now, this one has an off at the accounts, meaning that we have others where maybe the art is at off, meaning that we have 3, that is FLT, and art is off, and then role models and YSA, something like that. And
let me actually interrupt you. I'm sorry. This is great. I want to make a note about this because we get this question all the time, that factorial experiments, while complex, are efficient in calculating sample sizes. So people look at that and often go, it's a 16-arm RCT and you need thousands and thousands, but that's not the case. There's actually a formula. If you're writing this in a grant, a calculator, you can look and you can show reviewers that if I were to do like a similarly complex trial without a factorial design, I would need twice the sample size. And so reviewers like to see this in grants to show, like, to clarify, it looks scary, but it's actually efficient in terms of being able to look at all of these combinations in one study.
Yeah,
sorry.
Thank you so much, Dr. John. So you can tell, I also pulled out one that has 2 interventions. Now that is FLT and then models. Yeah, so these are just different combinations, but I pulled out a few to show you how this really works. Now this one has only 1 intervention, that is the YSA, and you'll find another one that has only maybe FLT, another one that has role models within the 16 conditions. Yes, and we have the standard of care or the usual care, meaning that we shall not be administering any of those interventions to that standard of care group. And with that standard of care, I want to highlight that all participants are receiving what we call the Anita's story. This is also a booklet about a young girl named Anita living in Uganda while exploring her experiences of living with HIV. So we are recruiting all participants, whether you're in standard of care, whether you're receiving these interventions, they are all receiving this more. They are all receiving this knowledge on how to adhere to their medication, at the same time on how to navigate through the different experiences of living with HIV in Uganda. So this is the breakdown of the framework, the MOST framework, the 2-factorial experiment. And yeah, maybe something I wanted to also share is that breakdown of the 2-factorial experiment. We said we have 16 conditions. That means 3 clinics per condition. Yeah, to make 24 clinics per intervention, and that makes all the 48 clinics that we are recruiting from. Yeah, the Greater Masaka region. So I am not going to spend a lot of time on the study measures, but I'll highlight that most of the questions that we interview these participants come from, basically you can look on the left-hand side, they come from the interventions that we're actually administering to these young people. We have the financial literacy training, and we can tell the different skills that we're using in that intervention. Alongside that, the economic empowerment interventions. We have the psychosocial intervention, and we also have the different skills under the psychosocial intervention. So maybe also to talk about the time points on how are we basically meeting these young people to ask them these questions or to interview them. We have a time point at baseline, that means that recruitment, and we also have, we meet them after 6 months. That means after we have administered these interventions, we meet them immediately after 6 months, and then after 12 months, 24, and then 36 months to see that progress. Yes. So I want now to talk about how far we've come, and I'm starting with the setting of the stage. This is so far where we come from. We started in 2022 when the grant was approved, and we started with the IRB approvals from UVRI, that is the Uganda Virus Research Institute, then UNCST, Uganda National Council for Science and Technology, and the Washu IRB. So we managed to get all the approvals for us to basically start. Apologies. Okay, so we managed to get all the approvals, the IRB approvals, to basically start this, to implement the Suubi Adherence4Youth study in the field. But we not only end there, we do not only get the IRB approval and then start going to the communities. No, we also have to now go to the district level. We talk to what we call the DHOs, or the district health officers. And after talking to them, they give us what we call the district clearance. Yeah, that means they have given you the right to start the implementation in that district. And after doing that, we now go to what we call the study introduction. We go to each of the 48 health facilities. We introduce the study and tell them, this is the study that we are bringing to this community. Are you allowing us to implement in your clinic? And then they also allow us to do this. And then we also now go to the implementation part on our side. The community has now allowed, IRB has now allowed, so now we are going to the implementation part. So the implementation part, and I'll be highlighting a lot of people that have been really getting this work going. We have staff training, because before we enroll to the field, we need all our staff that are going to be part of the study trained very well to engage with these young people with HIV. And we had the protocol training, the intervention training, and study measures training, and we then started the implementation. So what you're looking at there is the timeline. So allow me now to talk about in detail, maybe I'm just sharing a few of the pictures that we took as we started out the implementation. So I talked about the district clearance, meaning that we go to the district level and talk to the DHOs. We explain exactly what we are going to be doing in the field, and they give us the district clearance. So what you're looking at there, the first photo there is us meeting the DHO at Performancing. That's one of the districts that we're working with. And the second picture, we're meeting the DHO at Rengo district. And those are the people that you're looking at in the picture. Those are some of the people that we work with at the International Center for Charity and Development. I also highlighted something about the study introductions to the different health facilities. And these are the pictures I wanted to share with you on how far we are. Here we're meeting the Uganda Catholic Medical Bureau to give us access to implement under a hospital called, it's a very big hospital in Masaka region. It's called Chitovu Hospital. And then I also highlighted the study introduction at Kakata Health Center 3, one of the clinics that we're working with amongst the 48 health facilities. And I also talked about the staff training, where we had the good clinical practice training. Approximately 50 staff were trained on the GCP. And then we had the protocol training, and almost 54. We trained on this, meaning that I want to highlight that Dr. Fred and Dr. John were really influential in conducting this training. So we had the protocol training being conducted by Dr. Fred, where our staff involved, and they got to know what are we actually working with here. And then reviewing and training on study measures. I talked about the study measures. So basically, if we have staff that are going to be interviewing these young people, we need to train them on how to interview them, the different skills, what they mean, and how really they are related, the interventions that you're working with. We have also ongoing, these are ongoing, the data management meetings, how to deal with quality data, basically. And I want to also highlight that we have Dr. Sam and Ms. Fiona in Uganda, who have been influential in conducting these trainings, and also the intervention delivery training. And I want to highlight the RTY. Dr. Fred talked about the partners that we work with. We work with Dr. Ebo, and he was able to really help us on to training our staff on the economic empowerment interventions. That is the financial literacy training and the accounts training. Yeah. So I want to talk about the study progress and also talk to you about how far we are. So I want to first highlight that most of we usually have milestones from NIH, and our first milestone was on August 1st, 2023. We were supposed to be recruited. We were supposed to have 32 participants recruited, but by 3rd July, we had reached that target. And for the December target, which was 96 participants, by 17th July 2023, we had reached that target. And we had one for April 1st, 2024, but by July 31st of 2023, we had reached that target. And same with the August 1st, 2024, we had also reached that target by that time. So I'm actually grateful to the team that have been working with in the field, who have managed to really make sure that we reach these targets in time. And so all these other targets not yet reached them, but of course they are in 2024 December, so we shall be reaching them in a few months. So I want to maybe highlight some of the activities that we've been doing, and I've talked about the recruitment, and I've said we've recruited so far 352 participants out of 32 health facilities. And those that were recruited, we are recruiting in cohorts. So we recruited in the first cohort of 16 clinics, and now they started receiving their interventions. After receiving their interventions, so what you're looking at is the 6 months follow-up that I talked to you about in one of the slides. So what I've highlighted our percentage on how far we are on basically following up on our participants. And this also can show you by the time we finish our attrition. So here at we have around 5 clinics that are at 100%. Basically, we managed to get back all of them and interviewed them. Yes, and you can tell that the other numbers are also high, but allow me to go to the next slide. So I want to highlight a few people here. These people have been influential in the success of the study. And I want to first say that these are the enablers of the recruitment success. We have good participant mobilization and community engagement. This has been done really extremely well by the lady in between there. She's called Jenda Mlindwa. And I also want to highlight the team. We have Ms. Flavia Namwongi and Herbert Migati, those in the last picture. Those two have been really influential in the kickstarting of this project at the implementation level. And I want to say that we've been having constant communication. We've been having constant communication with our study PIs. And the picture that you're looking at, that was Dr. John and Dr. Fred with us in the field as well recruiting participants. Basically, they've offered the support that we need. Yes. So this is study intervention delivery. You can tell that basically we have been having, this is the attendance chart, been having really good numbers turn up for these interventions. Yes, so the line that you're looking at up there is the line of the attendance, really. And I'm out of time, but I want to really just go through the last slide and maybe share a few challenges that. For the challenges, and this is where maybe I'm going to stop. For the challenges, I want to highlight a key challenge that we faced, and that key challenge was missing young people and adolescent peer supporters. We have been working with the Uganda Ministry of Health to have young people and adolescent peer supporters work with us on the role models intervention. So what you're looking at there is the first picture that you're looking at. We managed to, the challenge that we had is some of the clinics didn't have these young people and adolescent peer supporters. Basically, people that can be role models to these young people. So we managed to train with the support of the PIs, and we managed to train young people from within 11 clinics. Those were around 20 peers. Managed to train 20 peers to be role models to these young people. Yes, so I want to highlight that, and I'm thankful to the team for that. And the other challenge that we got was basically the bad roads, the remote roads, and when it rains, it's really, really, really bad to get to the field. You can tell in the last photo there, we were stuck for around 2 hours trying to wait for that vehicle to move away from the road.
Oh,
Yeah, so those are some of the challenges that we face as we are going to the field. And basically, some of it also affects the participant turnout. So at times, people don't turn up because they can't access the clinic when it rains. You get, yes. So those are some of the challenges we face. And also maybe the photo in the middle is one of the peers receiving their certificate after the training.
One of the other last slide, Alan, like acknowledgements that you have. And I wanted to save time for questions.
Okay.
But thank you so much, Alan and Fred, for that. And just to say, it is just a mountain of work. And it's gone smooth, in part thanks to the team on the ground. And so with that, we can open it up for questions. I wanted to save some time for questions. There's also food that's out here for everybody, and so we can stay and chat as well or grab food. But yeah.
Anyway, great presentation, both of you. Really impressive. So I have two different questions. One is, explain a little more about the IGA, especially for this age group. What sort of examples of IGA are we talking about? What's uptake been like? Because you've been working with this sort of intervention for a long time. But I'd be interested to hear, it's not typical, I think, for children or even young adolescents to be engaged in IGA, but further, is this IGA for them? Is it IGA for the family? I'm just trying to understand that for one. And the other one's more technical, and I'm not a biostatistician, but maybe this is more for John, is understanding the factorial design and ICC, which is a big driver of power and sample size. So do you have to calculate ICC for all the various permutations? Or usually if you have a 2-arm trial, then you need ICC, you just need one ICC, but do you need multiple ICCs, and how does that affect your sample size calculation?
Okay, the IGA, that's an excellent question. So the reason we call it a family economic empowerment intervention is because the IGA is for the family. And normally what you're talking about people raising chicken, for eggs and for selling, people, sorry for those ones who are Muslims, but so people raising pigs for also selling, and people doing, some of them have done what we call backyard gardening and that kind of stuff. So something which won't take out a child out of school for them to engage in a kiosk. No, so we do very home-based IGA, and they're trained on that. And we have what we call IGA or goal-specific training. And so they go through that. That's the financial literacy pieces and IGA training.
Yeah, Craig, I'm just pulling up our data plan. And this is rope tour in here too, or maybe Rachel as well, I don't know. Because it's the clinic level, it looks like we've estimated it based on a prior study with Fred. But we only used, I guess, one, which is 0.02. I mean, I guess, I don't know if this applies towards the other principle of the factorial design is, yes, you are looking at multiple combinations and all of these different things, but you're really powering this to the one effect, which is the smallest component. So you can have all these components, but really you just need to power to the one with the smallest effect size to be safe. And that might be deeper a level of expertise than I have, but based on that, if you power to that, you are then powered to the bigger effects.
If the ICC is 0.1 for the other effects, you may be underpowered.
That's great. That's something to follow up on. Yeah. I don't know, Tor, is that?
Yeah,
there's a huge impact on.
Yeah, I mean, we have the luxury here of having prior data to use us to draw ICCs from, and typically we try to supply a range of plausible ICCs to demonstrate that the power would likely be sufficient running from, the lower ICC that we've seen in previous trials to the highest ICC. But
Maybe
those
you
are
wanna,
for
you maybe want to,
those are
for my own
RCTs,
benefit,
not necessarily factorials, right? So the
Yeah,
question
yeah,
you're asking is what is the influence of the ICC in a factorial specifically? I can't answer that question.
maybe you
yet.
just wanted to define ICC just because we probably have, for my own benefit as well. I know there's ICC and I know some important examples. Do I really know what it means? No.
Well, basically, it's the either intraclass or intracluster correlation, which represents the degree of similarity of participants within the same clinic or hospital. And the idea is that basically ordinary statistical methods would assume that people within the same clinic are just as unrelated as people from one clinic versus people from another clinic. But if you're within the same clinic, presumably your viral suppression, there might be some correlation if you and I are in the same clinic. So if that is true, then you and I are not contributing 2 persons worth of information. We're contributing somewhat less than 2 persons worth of information. And the higher the ICC, the less information, less independent information there is. So at an ICC of 1, your information and mine are perfectly correlated, and there's essentially 1 person's worth of information. At an ICC of 0, which is the other extreme, you and I are considered statistically independent, as if we were from different clinics. The real situation is usually somewhere in between. It usually tends to be closer to 0 and closer to 1, although it depends what's being measured. So we need to account for that when we're planning our sample size. We need to have maybe a bit bigger sample size because we have less information when people are correlated with clinics.
And we stratify by clinic size as well. So it's the 16, but it's stratified by the size to account for that. Like not all the biggest hospitals would be maybe more likely to be related, are not getting the same intervention components.
I think Sherry raised her hand.
Oh, so-
Can you go first? I have a question around how are you concerned about any sort of contamination between clusters? If one adolescent gets seen at one clinic, what's the likelihood that they might go to another one that's giving a different sort of combination of intervention? And if so, what are processes that you have in place to try and mitigate that or account for that?
Yeah. So that was the idea, Alan and team to talk about the distance, but that was the idea about randomizing at the clinic level. And I mean, at the end of the day, there really isn't great guidance in terms of like, you just got to ask, like the channel, don't talk about, what you're doing. But I don't know, Alan, how.
So we are in 7 political districts. 7 political districts would literally mean you are almost in 7 different states of the US. And the randomization was not simply at the clinic based on how they size, but it was also based on rural versus urban among these. So I think I've done this work a long time. Where I've had a crossover was in schools than clinics. I think most people don't change clinics that much, but schools, if someone owes money here, sometimes they push them into another school because they want to go to school. So, but like John said, what you do. But for now, I don't think we have had any where there is, where someone came from Bukoma and Simbi to go to Masaka, and so we have not had that. Yeah, but.
The DSMB asked us about to report on that, so that's they're monitoring that.
I wondered about too the acceptability at the clinic level. Do you have clinics that feel like we're the unlucky clinic because we didn't get the youth savings account, for example? Or...
That's actually a good question. Frankly, you're not taking away anything from them. So I probably, we are lucky that way that we have not taken away anything from them. So they still get whatever the clinic gives, and we have added actually an extra handout, the Anita story that some of these clinics are not able to print. So maybe it's in there, but I don't think that they have verbalized it to say, how come I didn't get this? But I think for as long as you explain the randomization process, well. And when you are working with clinics and you are working with healthcare providers who are, to use the word, you are at least, more sophisticated than a local person. I think some of them understand, this is a research and it's a study and that's what it is. So I think yeah. So we have not, I don't know whether, maybe Alan can say, but I've not had someone come to me and say, but Fred, why don't I get the account? So it could be because of the sophistication that they understand that this is purely research and you have not taken away anything that you are not withdrawing anything that they were getting before.
Yeah. Sherry,
Yeah. Thanks. This is fascinating, and I really appreciate you being here. I have sort of a question. I understand sort of the idea of the most design in terms of trying to understand what each independent component is providing and how they provide things in combination. But theoretically, do you think each of those components are going to impact viral load by themselves? I mean, I'm sort of wondering, like, will financial literacy training actually impact viral load? And theoretically, wouldn't you want to pair that with something else that has like an HIV focus and or that brings in sort of like the youth savings? I'm just wondering, like, for a most trial, do you have to assume that each thing can impact the outcome? And do you actually have data that would suggest each thing independently would?
Well, I think the more interesting question for us is the combinations.
Yeah.
Because at the end of all of this, ideally what you see is you'll see sort of, it takes you under the hood. So you're saying, here we have these components, we have these mediators, moderators, which we think theoretically should explain any effect. So we have the components, we can see the wiring, and we can understand, okay, this thing's not working the way we thought it would, or it is, but it's not affecting the outcome. And then you have the costing. So you can actually plot every effect, every combination, the cost, the effect size, and then you can make those decisions about, like, yeah, at minimum, we need this thing and that thing. And if we want to add this third component, it costs this much more, we get this much effect. And you can look at those. So that's like, really, you're just looking for more information to make decisions about, okay, now where do we go from here and picking out. So it's not like one, it's you come together with stakeholders and go, what do we want to like invest in based on the data that we have? So that's the idea. And then if you have that, ultimately, sure, you can then test it in an RCT. But I think the spirit of most is then we go back and say, actually, how do we make it even faster and lighter and more efficient, so you keep iterating. So that's the goal.
And I don't know if someone else had a question, but my second question, I'm just curious if you can comment on the anti-LGBTQ laws and right now going on in Uganda and how that's impacting just sort of HIV work. I mean, I know that's not related to this particular presentation, but it's of interest, I think, to folks here.
Yeah, so, I've had discussions with the ministry, and, they're evasive about it. And what they say is that we are not pushing, we don't send anyone away when they are getting service. So they have tried, and, last year I took students from the US and we are in the parliament. And this same question came up, and the way they are addressing it is that we will not allow politics to interfere with the means of health services. That we are not. I think that's the argument they're making, that we are not pushing away anyone who is entitled to services. That's what they say. Mm-hmm. Now, I don't live in Uganda, and when I go, I can ask questions and I can look. I've invited a minister. She's going to be here at Washington University in April, and this question will come up. This is the Minister of Health, and she's a medical doctor by training, Dr. Chen, and hopefully these questions will come up. But that's what they say, and I'm not a service provider, but I know that none of the team, that no kid will be sent away, or we have not gotten any guidelines or saying anything that don't serve that. In fact, at the local level, that's almost unheard of. Really, frankly, at the local level where I work in the rural areas, that doesn't come up. But within the confines of Kampala, it may be different. Because I don't work in Kampala, I work in Masaka, and the minister has made it a point and the means to itself that politics is not going to impact the services they provide to not only the key population. I have another study which is focused on, women and men engaged in sex work, and they have not taken away, my approvals. They have not taken away Uganda National Council of Science. Have not taken away any of that. So I don't know whether it answers your question, but that's what I see. Unless you guys have anything to add, Samir and the other. But yeah.
Well, I want to be mindful of the time. We're at the hour, but we can stay if you people have questions. There's food and we can chat. Rochelle,
I wanted to end with that map, and maybe there's another, and to tell you that we need all of you. So we need a village. If you go to the last slide, we need you guys to be able to engage with us in a very meaningful way. So there are so many laws, unfriendly laws in the country, and in some of these, Ghana has just passed, I think, a similar law, unfortunately. But I think that we should try to, keep the politics out, because these families need us, and as scientists, we need to be there. Okay? So it will take a village.